Good morning, everyone. We're going to go ahead and get started. Happy Saturday. My name is Brandon. I am 37 with cystic fibrosis, and I'm excited to be here this morning talking about doing DEI in the real world. I live in the greater Cincinnati area. It's great to see some of my care staff here. Married, two dogs, two cats, and a potbelly pig. Those are our four-legged children. And DEI is really just important to me as a person, but also to CF. Diversity looks very different for each and every single person in this room. But being someone with CF, you often feel that you are just a diverse individual, sometimes feeling alone. Also being a gay male, there's some other layers of diversity in there. So this is really exciting to be able to talk about DEI for what's happening in some of our care centers, and then also maybe what each of us can start to do for our care centers as well.
Good morning. I'm Chandra Gordon. I'm a pediatric social worker at the University of Kansas Health System. And so I'll turn it over to Brandon to introduce our first speaker.
All right. So health inequities and social injustices are truly part of the past, present, and future. I think when we start to talk about the past, present, and future, we become part of the history, and that can be everyone in this room. Research tells the story, and so do the voices of those impacted the most. There's a lot of talk about inequities and making changes, yet very often little action is done to take place. Things are being done. We're going to hear about 5 of those things just this morning to address inequalities in care centers. This session is going to highlight the initiatives that are taking place to promote diversity, equity, inclusion, and belonging. This session is going to provide the audience with strategies that can be implemented at the personal, patient, and team level to promote DEI. Our first speaker is going to be Abby Gutierrez. Abby is from the Children's Hospital of Colorado as a pediatric psychologist. Abby?
Hi, everyone. I'm so honored to be speaking here today. I just want to start by saying that I am so impressed by all of my colleagues and peers here. I've been exposed to such incredible information and learning over the past few days and feel grateful to have the opportunity to share my personal passion project with you all. So I'm proud to introduce SIB-SOAR, Siblings Supporting Others and Achieving Resilience. I would also like to extend a special thank you to my mentors, Dr. Emily Muther and Dr. Emma Lyons, and to my incredible CF team at the Children's Hospital of Colorado. Okay, I have no disclosures. Okay, so I'd love to provide some context as to how I got involved with the sibling population. As most of us know, a child does not exist in a vacuum. It's important to consider the different systems in which a child lives and is affected. So one of the most important systems, as we know, is the family. So there is some significant research into how caregivers are affected by having a chronically ill child. However, we've seen more limited research and focus into how the siblings are affected. And it's important to think about how they are also part of the system and how they adapt, cope, and impact their family. So there are a number of studies that have looked at this group, but really more broadly about children with chronic illnesses, not CF specifically. So while this limited research that we do have on CF-specific siblings, it shows that they're more likely to experience higher rates of depression, anxiety, anger, school problems, behavioral problems. And these non-CF siblings often go unnoticed in the care of their siblings. Like, how often can you think of asking parents or caregivers, well, how are your other kids at home? Or providers asking, how are the sibs doing? Not often. So we know that there are really good mental health guidelines for screening kids with CF and for screening caregivers. But yeah, again, we don't know, the current literature is not there to support how siblings are being screened. Okay, so I want to talk about some previous sibling interventions. And again, these have been for more broad groups, chronic illnesses. They've utilized different evidence-based techniques, so CBT and ACT primarily. Several groups have been based on this model of sibling adjustment developed by Carpenter and Soller in the 90s that targets interpersonal functioning, intrapersonal functioning, communication, and fear of disease. So the interventions that have been utilized have shown benefits to self-esteem, coping, sense of belonging, improved family relationships, anxiety, and depression. Additionally, targeting these factors, one thing I mentioned was family functioning. Family functioning has been shown to relate to positive health outcomes for kids with CF. So things like better adherence, improved growth, and even better pulmonary functioning. So this is something really interesting that we can think of as an impact for our system that maybe we can communicate to providers to help them get on board with this. So again, to date, there's no specific intervention for siblings of children with cystic fibrosis. Okay, so I wanted to create this group intervention that was specific to this specific population while also incorporating evidence-based techniques and practices with specific theoretical underpinnings. So how and why did we decide to create this group? Well, it not only came from my own personal interest, but also our clinic needs. Our provider team were hearing more from parents like, how do I support the sibling? They're really stressed, or they're anxious, or they're worried about their sibling with CF. So after about 6 months of IRB processes and creating a manual, SIBS4 was ready to implement. I also want to mention that I was working on this as part of my 1-year postdoctoral fellowship, so this timeline may not be realistic for everyone. One factor that I want to acknowledge was how we recruited. So we have a pretty large census of about over 400 patients in our center. So we have also good ways to communicate with those patients. So we have a great coordinator who gave me an email list of all of our patients, and I was able to reach all of our families across many different areas of Colorado, including rural parts of Colorado too. We also talked to patients in clinic, and we gave them this lovely flyer. Shout out to Canva. For those of you who know, you know. We also spoke with our family advisory committee to kind of ask them, like, is this something you think that patients would like? Is this something that would impact your family positively? And one of the families actually in the advisory council had their daughter participate and gave good feedback. So another important thing was collecting data. So we were part of the project was giving consents, in a sense, to families, and also doing a Qualtrics online survey, pre and post, that the parents and the kids completed. And then you're probably wondering, how did I bill for this? Well, we didn't. So this was part of a research study, so we didn't need to bill for it. Also, another consideration is that I was a trainee at the time, and in our hospital system, trainees don't bill for services. So that was kind of a workaround we had. However, another workaround is that we worked with social work to facilitate this group. And so I know in a lot of systems, social workers don't bill, so maybe having them facilitate this group could be an option. In charting, also another important thing that came up. So because the siblings were not patients at Children's for most of them, we worked with our team to create charts for those kids so we could document. Okay, so here is a very general overview of the group format. We had 4 one-hour virtual sessions, children of all genders, ages 9 to 14, developed with these ACT and CBT principles, and also some flexibility to process and talk about the things that were most important to the group members. Additionally, we sought to kind of target these factors that we know impact sibling adjustment. Okay, so yay, the exciting part, where I get to show you examples of what the actual intervention looks like. These are the first 2 pages of the sibling workbook, where we sent this to families ahead of time to print and have at home so the kids could follow along. There were exercises that they could color and write on and keep as like a little memory journal of the group. I think in the future, we would hope to send it out ahead of time to remove that burden from families and to make it more accessible. Okay, here's the overview of the 4 weeks and the content that we covered. So week 1 was an introduction. We talked a little bit about the knowledge of CF these kids have, a little bit into the CBT of it all. And then the next week we did emotion identification, mindfulness. Third week, we focused on communication with some really practical exercises. And the last week, we rounded it all out with values, identity, and some cognitive diffusion. We also started each week with a fun icebreaker exercise and ended with assigning a brief homework exercise that we would discuss together at the next session. Okay, so I'm showing some content examples of each week. So for week 1, we wanted to target what the kids know about CF and what they know about their siblings. Something interesting we learned is that these siblings have a wide spectrum on what they know about CF. There were kids who didn't know anything about CF, which caused anxiety and unsureness. And then there were kids who knew way too much, arguably, about CF. And this caused even bigger anxieties and worst case scenario type thinking. And we know the data and the literature shows that CF has changed a lot. So they're going to Google on their phone and they're seeing the life expectancies and they're not talking to their parents because they're kind of freaked out and they have this inside. So just getting to talk about it was really helpful to our patients. Okay, and this is the homework exercise we did, which they were really good about doing homework, which I love to see as a clinician because it's a little scary. Sometimes when you're assigning it, you're like, oh, I don't know how they're gonna react to this, but they did great. Here is just, I just wanted to show you what the therapist treatment outline looks like, and just some of the questions you can ask for the icebreakers and just giving us a little more structure when we were implementing this. Okay, so for week 2, we targeted emotion identification and the brain and body connection. So we used the emotion wheel to share stories about when we felt a certain way. We also used this example on the right as an activity to draw and color where we feel feelings in our body, with an emphasis on how it's human to feel and there are no right or wrong emotions. We ended this session with a progressive muscle relaxation exercise and encouraged the patients to recognize when their bodies might need a little extra relaxation to feel better. Side note, kids love this. Tensing, I'm sure I sing a lot of nods, but tensing their butt is their favorite part. So it's really funny, they love it. I also sent a YouTube link to families so they could help with it. And there's also a script in the manual if parents wanted to narrate it for their kiddos outside of session. Okay, so week 3, we focused on communication and interpersonal functioning. And I wanted to share an exercise that really resonated with the group. So in this postcard activity, we asked kids to write a message to a family member or a friend that they wish they could talk about their sibling CF with. Then we practiced saying it together as a group. The members reported things like, I wish I could tell you about my problems, but I know you're more worried about my sibling. Or, I wish we could spend more time together, but it's not as important as getting treatments done. Or, I'm worried that my sibling will die and then my parents are going to get divorced. I know, this is heavy. Once, one of the kids, a 9-year-old male child, said, wow, we just got deep, which I loved. And from what I saw from this was unwavering support and validation, not from the facilitators, but from the intergroup members. They got it. For the first time, they were with other kids who understood their unique experiences and thoughts. They all reported relief and happiness in being able to get these more difficult things off their chest, but also to find a sense of community. Week 4 was a little bit more flexible, so we needed to kind of process some of the emotional heaviness from week 3. And then we spent some time talking about values and identity outside of being a sibling, like who are you and why is that important, right? And really celebrating their individual differences. Okay, so this is a very brief overview. There's a lot more content there. I just want to quickly talk about the measurement that we were able to do. We did a combination of some qualitative and quantitative measures. And again, this was for parents and children to complete. So here we have some questions, and then quantitatively, we use the sibling perception questionnaire, the PEDS QL, the SDQ, and the satisfaction with therapy and therapist scale. Okay, so some of our qualitative feedback. This group helped me feel supported and connected. Connection was a huge theme that we saw. I felt safe to talk about my frustrations, like validating the hard thoughts they're having. And then a parent saying, my kid loved it. Afterwards, they want to do another class. And so we ran 2 full sessions of the group. We did one in the spring 4 sessions and one in the summer 4 sessions. And 2 of our kids in our first group actually did participate in the second round, which is really exciting. So preliminary outcomes, and this is what I call my baby data, okay? Baby data, it's an infant, we're raising it. We had 3 participants in our first group, and again, my timeline was so kind of condensed that I kind of, as soon as I got IRB approval, I was like, I need to run these groups. So we got 3 participants in about a month of recruiting, which I think is not bad. 3 completed the pre-survey, 2 completed the post. And then our group 2, we had 6 participants. 2 were our fabulous repeats, which we use kind of clinical, like, understanding to think if that was a good reason or not. But we did decide to have them join again. And 3 were siblings, so 1 family of 3 kids who, they didn't have CF, but they were in 1 unit, and they only went to 1 session. It was, I think the family had like 7 kids. It was just a hard priority to set. And then we had, again, 3 completed pre and post survey documentations from that. And then the data analyzed, so we looked at the 3 participants, so 2 from the first group and 1 from the second group who attended all the sessions. So these are the unique like data points that we looked at. We didn't look at the repeats. Okay, so what we saw, and again, baby data, the sibling perception questionnaire had the biggest kind of drop, indicating better adjustment, which was the most specific thing that we were looking at in this intervention. We saw the PEDS QL, like, it did go down slightly, which indicates worse kind of overall health outcomes, not necessarily looking at mental health specifically, but again, little decrease there. And the strengths and difficulties questionnaire, again, a slight increase, which means more, behavioral or emotional concerns, but not significant. Also, we didn't do significance testing because, again, our sample was baby. And the therapist satisfaction was a really high score. It's from a 0 to a 60, so a 52. I'm really proud of that they enjoyed the group subjectively, and it made having a sibling with CF better. Okay, future directions. We would love to continue running this group, adapting the manual, collecting more data, and potentially assessing the feasibility of implementing in more CF centers. And you did it. Thank you so much for participating. This is my email and my contact information. Thank you.
So we do have time for questions.
Hi, I'm Lauren Lazar. I'm a pediatric GI at UT Southwestern. This is a great idea and really well-run study. I had a question. You may not have enough data yet, but did you notice a difference between older siblings versus younger siblings?
Yeah, so originally we were hoping to do 2 different groups, one for kids age 9 to 11 and one for kids age 12 to 14 to kind of assess for that developmental differences. But just by who actually wanted to participate in our numbers, we actually ended up combining them, and they did really well at this content level for their abilities. I will say a 9-year-old and a 13-year-old can be different at times. So a little more distractibility, like we're virtual, like we needed to like really engage. So I did notice developmentally that there were some differences, but the content was still digestible and appropriate for those kids. Also, I did notice, and this was different. We had 2 9-year-olds. One was like, life is good. I'm chilling. I'm not worried. And one was like, I think about my baby brother CF literally all the time. So it's going to be very specific to each individual kid. Yeah. Thank you.
Thank you.
Hiya. First off, that's just a gorgeous piece of work. And I think baby data is better than no data.
Thank
so
you.
It was awesome job. I'm Maggie. I'm a social worker and researcher. My researches in adults with CF and identity, and I love that that was weaved into this project. So I just wondered if you could speak some more about any findings you had around values and a sense of identity. Yeah, thank you.
Yes. So something that comes up a lot in the sibling population is their identity is being a sibling to a kid with a chronic illness, caring for them, worrying about them, making sure they're taking their medication or making sure they're not playing too rough outside or wearing their mask. And they're thinking a lot about, man, I just want to make sure my sibling is okay, and not as much about like, who am I? What do I actually like? You know, they're like, oh, my sibling likes this. I'm going to play with them and help them. So that was something that was coming up, and they were saying, wow, I've kind of never thought about this. What do I like? What do I value? And a lot of them, I did notice a strong family value, that they valued connection with their family. But also they were like, maybe I value being funny. Ha ha ha, I'm funny. And we would also end sometimes with a show and tell, and we saw a lot of funny things. A cow. We're in rural Colorado, so like I was seeing the whole farm. But really just, they were so open and they blossomed when they were like, wait, I get to talk about me. It was a beautiful thing to see them really kind of find that. Yes, thank you.
All right. I know this is a very important topic, even for myself. We have a couple questions coming in. I wish this was kind of out there when I was growing up. I have an older sister without CF and a younger brother with CF, so this I think would have been very helpful. The first question is, for SibSOAR, do we have any adverse events that became more noticeable in siblings, and how did you handle that as they were not patients?
Yes, we actually did. So for one of our siblings, her younger brother was going through a particularly rough time with his CF. Nutritionally, he wasn't gaining weight. He was also recently diagnosed with autism, and they were having a lot of conversations around if a G-tube was appropriate for him, which in her 12-year-old brain, she said, if he gets a G-tube, that means he's dying, right? Right? And so this was something that we could process together. Wow. Have you said this at home? Have you asked your parents about this? No, I just heard that he's getting a G-tube, and that must be really bad. So really holding space for things that were coming up in real time for these kids was so important. And by the end of it, she was using some of the growth mindset skills we learned and said, this is scary, but scary stuff has happened before, and we've got through it as a family. He's going to get through this G-tube. Way less anxiety as a family, too, which is great, because I also worked a lot with her mom in clinics, which is great. So, yeah, thank you.
Awesome. We have one more question. This person might have said they missed this in the beginning. Was the sibling perception questionnaire one that you created, or where did that come from?
Yes, so this is something that was already created by Carpenter and Soller, who were some of the original sibling researchers. I actually found this measure when I was doing my dissertation in grad school, and I validated it. So if you search it, my research will come up, which is actually really frustrating when you have a question about a measure and you want it to get answered, and your paper comes up and you're like, I know this will not help me. But yes, it's a really good measure that's really specific into sibling adjustment and has pretty good internal consistency and reliability with the other measures that I used. So I do recommend using it.
Thank you.
Thank you.
Okay, we're going to introduce the next speaker we have is Leah Ratner. Leah is a MedPeds physician and global health equity researcher at Brigham and Women's Hospital in the Division of Global Health Equity.
Thank you. Thank you so much. It's an honor to be here. I'm Leah Ratner. I use she, her pronouns. And I first just want to start off by saying I'm speaking on behalf of our entire group. This is not my work alone. Community effervescence. This is a sociologic concept that I'm sure everyone in this room has experienced. It's the idea that when we come together as people for a shared purpose, it brings both unity and joy. I recognize that we all bring different perspectives, expectations, and feelings about equity work in CF care. Some in this room may be experts, while others may be just starting on this journey. Regardless, I hope this presentation serves as a reminder that none of us are in this alone. So as we navigate these ideas together, let's remember we're here to foster change collectively. So now imagine that we're embarking on a journey together, one of collective. Anytime you think of these concepts now and in the future, remember this moment in time when we were all here together for shared purpose and shared change. If you ever feel isolated in your center, remember that you're not alone and that we can all come together to do something beautiful. So here are our disclosures. As a team, we acknowledge the sacred land where we work, live, teach, and build community. We recognize this land is home to the Massachusetts people where they've been for 13,000 years, and we recognize this land is unceded. We also acknowledge the many worldviews that we have that help inform the way we approach our work. Though we may represent many non-dominant identities, we specifically want to acknowledge that we sit in a place of privilege working at an elite academic center, and this may result in blind spots. So we thank our patients, and specifically our Patient Family Advisory Board, for supporting us and helping us uncover those blind spots. I also want to recognize and show gratitude for my funding, both from the NIH and the foundation. So I'm going to start us off with 2 patient experiences. The first one, a new patient to our clinic. The EMR banner read, the patient was requesting an interpreter. The provider, who didn't yet know the patient, saw the last name and thought, I think it sounds like they speak Spanish, and called a Spanish-speaking interpreter. The patient actually needed an ASL interpreter. Another example, on a programmatic level, several years ago, we realized the data we had around patient-facing non-dominant identities, ethnicity, racial identity, sexual identity, and gender identity, for example, were inaccurate or incomplete in both the EMR and the ZF registry. We would never support inaccurate or incomplete data in any other situation, so we set about to correct this. It's been an iterative cycle with iterative feedback, and recently we received feedback from a patient that the term homosexual was offensive to some. So we adjusted our process, taking the word out and reordering the language. I'm also going to share a personal story. This one is very hard, but in a talk entitled Embracing Productive Discomfort, I felt that I needed to model it. And also, I'm following in the footsteps of so many brave people living with CF before me. I have a dynamic medical disability. Several months ago, I presented to the emergency room with what I knew was going to be a spinal cord compression. For those non-doctors in the room, it's usually a pretty obvious diagnosis, and everyone knows that's a true neurosurgical emergency. On the way to the emergency room, I called my best friend, who's also a doctor, and we were met by a physician assistant and an attending at the hospital who said, "You look fine. I don't want to do an MRI in the middle of the night, and I really don't want to call neurosurgery in the middle of the night. Why don't you go home and follow up with your PCP in the morning?" Well, the next day I did, and it turned out I had an emergent cord compression, and the delay in diagnosis was and continues to be clinically significant in my life. So now, I'm going to ask you to hold these 3 patient stories as we continue through this presentation. You will need to hold multiple perspectives, but I trust this group can do that. So now, let's consider these stories from a patient perspective. These stories may have made you uncomfortable. Today, we're not talking about unproductive comfort. Hopefully that's sitting at home in your jammies on a Sunday night. We're not talking about unproductive discomfort. That's when it's traumatizing. What we're trying to talk about instead is productive comfort and productive discomfort. Productive comfort is that feeling of growth. It's when you surround yourself with people who push you just enough to feel a little bit angsty and you grow. Productive discomfort is that nagging feeling that you hurt somebody's feelings in a conversation, or maybe you had a blind spot that you just didn't recognize. We bring these together at the intersection of curiosity. Why did that happen? Why do I have that nagging feeling? What's helping me grow? And humility. Did I do something wrong? How can I grow? And where are my blind spots? To create a shared humanity. So this talk is called, in the talk we use the word praxis, which may be a new word to some. This is praxis with an X, not practice with a C. It was a term originally coined by the Brazilian philosopher Paulo Freire in the 1970s in his famous work, Pedagogy of the Oppressed. It is the idea of the true embodiment of equity. It's a cycle. So let's give an example. We understand in this room, hopefully, that equity and equality are not the same thing. Equity means giving more to those who are facing structural violence. Well, equality is giving the same to all. Though we may understand that, applying it can be challenging. I'm sure everyone in this room has tried to apply it, and as you acted, recognizing going from theory to action, you were still left with that nagging feeling like something wasn't right. So now let's go back and reflect. Was something missing? What about that action brought discomfort? Leading us back to theory, did we have the entire theory? Maybe we needed to think about it from a feminist perspective, from a disability justice perspective, or an intersectional one. So we go round and round in the pursuit of liberation and justice. It's a process that's forever ongoing, and it looks a lot like something else, right? We thought so too. The Plan, Do, Study, Act cycle, which is a quality improvement metric originally coined by the IHI and is a very standard method for when something doesn't go right in the hospital, clinic, or health system. It's iterative as well, and it's supposed to address problems in the health system. But what we realized is quality improvement alone will perpetuate the status quo without intentionality to equity. It may solve issues within the hospital, but without this intentionality, we will never achieve justice. So we created our own model, which includes as you see in black, theory, action, reflection, and as you see in pink, the PDSA cycle. It continuously rolls and is continuously iterative. So here is our model. I know it's a busy slide, so I'm going to start off by just plugging our poster if you want to look at it more closely. And I'm going to orient you. Down the left-hand side, we have Plan, Do, Study, Act. You'll recognize that as quality improvement. And across the top, we have theory, action, reflection. You'll recognize that as the praxis cycle. And at the intersection of each are questions to hold yourselves and your teams and your community accountable to your work. So let's start with some examples. We're about to start the project, right? And at the intersection of plan and theory, here are our questions. And let's go back through the cases that we started with. So, why didn't I get the MRI when I needed it? What underlying assumptions were being made about me in that situation? I'll tell you, several months later, the chief of the ER called me, recognizing that there was a sentinel event, and together we did a root cause analysis. Similar to PDSA, another type of quality improvement. And together we realized that wasn't enough. The true etiology of the mistake was medical ableism. So together we presented the Morbidity and Mortality Conference. She presented the clinical case, and I taught about medical ableism. I will tell you, to a group of physicians that did not know the word ableism before we started. And that's because I have a medical disability. And both the attending and the physician made the assumption, but you look fine. And therefore, didn't further investigate, didn't think about my past extensive medical history to help come up with a diagnosis, all leading to additional morbidity. I use this example not because I have cystic fibrosis, but because cystic fibrosis often emulates a similar process of a dynamic disability. So let's talk about the other example, the ASL interpreter. Why did this happen, and what were the underlying assumptions here? Well, because the person had a last name that sounded like they spoke Spanish, which they may have, there was an assumption that they didn't speak English, they didn't need a different type of interpreter, but most importantly, that they were not part of the deaf community. So our team recognized this, set out to start learning ASL, and helped put a better identification on the patient's chart. So the next question, how do power dynamics and structural inequalities influence this issue? So I will start off for saying in my situation, the power dynamic was quite obvious. As soon as I became the patient, I lost considerable amount of power to advocate for myself. But I want to say, I recognize I am both white presenting and identify as such. I have high health literacy, I speak English. All of those things made it better for me. There's a million reasons and other identities that would have even perpetuated and made the situation worse. For our program, I will say the most important power dynamic is buy-in from our leadership. And I specifically want to say our medical directors, Dr. Amit Euler, Dr. Elaine Cagnina, they're so dedicated to this work, and without that, I don't know how we would sustain this project. We have this amazing multidisciplinary equity committee, which are both my colleagues and my dear friends at this point, as we meet regularly and we create a dedicated space to hold these conversations, to push each other, to grow together, and to recognize when these power dynamics are happening and to unpack them. So let's give another example. The intersection of action and act from the PDSA cycle. How do we refine our actions to better address root causes? And what new actions are needed to sustain progress? I often get asked, we did it once, now, right, it's over. But that's where we forget the iterative nature of both cycles. So to answer this one, I want us to look at some identities. So I'm going to give a quick example. Let's say if I was as an outcomes-based identity, let's say my goal was to be promoted to assistant professor for my work in CF Care Equity. We all know what the things that one would need to do that. Apply for grants, write papers, innovate, see lots of patients. And then one day, maybe I would say, I'm an accomplished assistant professor. But is that congruent with the way I see myself and my work? I'll tell you, no. At best, I would have moral distress. At worst, I would be burnt out and do something else. So your identity must align with the way you see yourself and the way you want to be understood in this world. So moving yourself more towards a process-based identity can help. So now, what if my goal is to improve CF Care equity? How would I do that? I surround myself with people who share the passion, who push me to grow, who help me uncover my blind spots, who help me empathize and listen deeply with my whole heart to my patients, and help me, therefore, maybe still submit papers and abstracts, but use those platforms for change. Now, I can see myself as someone who is rooted in justice, someone who's a good listener, and someone who uses their platforms for change. We can never be all just one or the other. But I often say, in my global health work, in the global north, we tend to be more outcomes driven as we see time as linear. But in places where uncertainty is expected, things can be a lot less linear and more intentional to the process. So pushing yourself to become more process oriented, if you find yourself on the goal oriented side, can help and sustain this work. And can help sustain not just personally, but collectively. Lastly, I often hear residents ask, or trainees ask, why are you talking to me about racism, ableism, sexism, et cetera? Talk to my attendings. Talk to the leadership of the hospital. They're the ones that don't know this and need to do this. While that may be true, it ignores the power that each of us hold in our own positionality. Even if your team, your hospital, your program is unsupportive, you still have complete control of yourself and the platforms you choose to use. So here's a way you can go through the practice cycle yourself. Remember, you're sitting and are you self-reflecting at the edge of your comfort zone regularly without going over? Are you getting feedback from your colleagues, and are you acting on it? And are you incorporating it and then reflecting on it and noting where and why those uncomfortable feels are coming up? So if you take away nothing else from this presentation today, remember the quote from our poet laureate Amanda Gorman, "Empathy emancipates." We are all here today because we believe in change, and together we share common humanity. I hope that next year and the 365 days in between, you remember this moment of community effervescence and that you are not alone in this fight for change. Lastly, thank you for giving me the space to share my story. Though hard to talk about, sharing my pain to make change for others is so healing. Thank you.
We're going to open it up. We have time for a few questions.
Sorry to hog the question space. Just really any tips and advice. Sometimes when I personally feel uncomfortable about a topic, I'm almost so scared to open up that dialogue and ask questions for fear of offending, right? So just any tips on what to bring to that conversation or how to set it out in a way that goes, I'm curious, I may say things wrong, and I'm here to be educated rather than offend. Does that make sense?
Yeah, it makes total sense.
Okay.
I was bringing us back to that intersection of, there we go. I think this is my personal view, but I think starting everything with both humility and curiosity together, exactly as you're saying, understanding that we all have our own stories and we all have our own lived experience. And so sometimes asking to hear those stories and then relating. I know personally in medical school, back when I was in medical school, there was such a dogma saying don't share your own stories, keep those boundaries. And I personally believe in sharing and connecting so much. It's helped me both as a patient and as a provider understand people as their whole self, and making those mistakes are okay if you have that shared humanity, right? Does that make sense? Yeah, thanks for that question.
Okay, we have a question online. Did you experience any pushback speaking with clinicians about medical ableism, and how did you handle that?
Yeah. I think that question is maybe specifically talking about the M&M that I did. Actually, in preparing for that, I will share, I had sort of a slide about the power and privilege wheel with different identities. I'm sure Angela Duckworth's slide, I'm sure many of you in this room have seen it. And when I showed it, I sent the slides ahead of time, and I was told, this is gonna make the white man uncomfortable. Would you mind sharing more of your vulnerability and your story so they don't feel so vulnerable? And I sat with it for a long time. And I was like, in this situation, I'm both the provider and I'm not the provider, I'm the patient, but I'm also like being brought in because I'm somebody that talks about medical ableism a lot. So I was willing to kind of put myself in the more uncomfortable position. But if I was teaching, when I do this with fellows and trainees, I would probably have not allowed that because it's not a best way to model shared vulnerability. In fact, the opposite happened to me last week, where someone said, can you teach this course, but nobody's gonna participate. Some people are asynchronous, some people are have their cameras off. I said, no, I can't talk about shared vulnerability and thinking about identities if people aren't fully engaged. It's gonna create an unsafe space.
So Abe Sender from University of Vermont, doing a lot of work in this space of LGBTQ folks, and the biggest question I get asked all the time is about what if I say the wrong words? What if I mess up? And obviously this is so adjacent to that. And I wonder only if you're comfortable in your experience, with that PA and that physician who made a mistake. I worry that people then, like comparing to the LGBT community, then they recognize they make the mistake, and then they're so over apologetic that it puts it back onto that person to be like, it's okay.
Yeah.
When in fact, it's not at all okay, and everyone in the room knows it.
Yeah.
I don't know what the question is, but can you reflect on that?
I love to reflect, so sure. So in that, I'll tell you something, in that experience, that was not the situation. I wish I got an apology, but he did not. But I've been in that situation where people are like, when I'm like, yeah, so what I'm feeling, wait a second, you are criticizing what my body can do and cannot do. Please, can we talk about celebrating it? It's hard though. It's hard. I think I try my best to just share my feelings and why I feel this way and sort of why I'm struggling in my body. I get angry at my body, and so often try to share that as well, as just to like open up the conversation. I think these things just start with conversation. So I do hear you that the overburden can then sometimes be on the person experience the marginalization. And it sucks. It just sucks. I don't know any other way to say it. Yeah.
All right. Thank you, Leah. All right, our third speaker is Kim Reno. She's a senior manager within the Policy and Advocacy Department at the CF Foundation. Welcome, Kim.
Thank you. I want to thank Brandon and Chandra for inviting me here to allow me to talk about our work in developing tailored communication strategies to enhance support for health-related social needs among people with CF. And of course, the disclaimer, and I do not have any disclosures. So there's a growing body of research focused on understanding the impact of social determinants of health, or SDOH, on the health of people with cystic fibrosis. Some research has found higher instances of SDOH-related challenges among the CF community when compared to the general population. For example, in the 2019 Health Insurance Survey, we found that people with CF were 3 times more likely to experience food insecurity than the general population. Given the prevalence of social risk factors among people with CF, the Foundation has prioritized educational efforts for the CF community and CF clinicians. And as an example, as you can see, we've created a social determinants of health toolkit for care teams that is available in the my.cff.org resources library. The terminology used to discuss social determinants of health is inconsistent and it's complex. Things like social determinants of health, social drivers of health, social risk factors, health-related social needs, and many, many more, as you can see here. The lack of consistent language and messaging demonstrates the need for clarity in order to best communicate with the CF community. And for clarity, here is the distinction that our team used for this work. Social determinants of health, as defined by the Centers for Disease Control, are the non-medical factors that influence health outcomes. They are the conditions in which we are born, grow, work, live, and age, with a wider set of forces and systems shaping conditions of daily life. Social risk factors are defined as the adverse social conditions associated with poor health, such as food insecurity and housing instability. A person may have many social risk factors, but fewer immediate social needs, which is why patient-centered care and engaging individuals in conversations about their unmet social needs are crucial to identifying which need is the most pressing for that person at that moment in time. Health-related social needs, as defined by the Kaiser Family Foundation, are an individual's unmet adverse social conditions, such as housing instability, homelessness, and nutrition insecurity, that contribute to poor health and are a result of underlying social determinants of health. Less is known about how people with CF perceive the impact of social determinants of health and how care teams assess for and support people with CF navigating SDOH. General information is lacking on how to discuss social risk factors with clear and concise messaging that resonates with the lay audience and the CF community. This project sought to explore the experiences and perspectives of CF community members regarding social determinants of health, and to understand how to talk about SDOH in a way that reflects and resonates with the CF community. Information gathered from this project will inform communication strategies that will be implemented when developing and disseminating educational materials for the CF community, including clinicians, people with CF, and their families. For this project, 11 people with CF and 4 caregivers, including 1 person with CF who is also a parent of a child with CF, were recruited through the CF Foundation's Community Voice. Community Voice is a group of more than 2,000 members who engage in providing input and insights to inform CF care and research that benefits the CF community. Recruitment included those who fell into one of 3 categories. First, people who have not personally experienced these challenges. Second, people who experience those challenges, or who never experienced those challenges but were concerned about having them in the future. And finally, people who had or were experiencing those challenges at the time of recruitment. In November and December of 2023, 6 focus groups were held, and participants were involved in 1 45-minute semi-structured audio and video recorded group with 1 focus group conducted in Spanish. Focus groups were recorded and transcribed, then independently reviewed and coded by 2 reviewers using in vivo software. After an independent review, the reviewers together came up with some themes, and once the themes were identified, the focus group participants were presented with the themes for reflection and prioritization. 6 themes emerged and are ordered as prioritized by the focus group participants for the remainder of this talk. The first theme is the recognition that people with CF are unique individuals facing distinct challenges. People with CF have different experiences, preferences, and priorities. Consequently, caution should be exercised in making assumptions about how people are impacted by their circumstances. Participants advocated for the removal of generalizations and for recognizing people with CF as individuals. One participant said, and I quote, "There's a difference between how is your CF going and how are you doing? Like the other aspects of us as people are sort of getting left out and getting left behind. Everyone has plenty of physical issues, mental issues, stressors, difficulty with relationships, work, and then you add CF on top of it, that's sort of compounding interest. We are learning there is a bi-directional relationship between SDOH and CF. While social determinants of health impact CF health outcomes, having CF also impacts a person's ability and their social needs. Recognizing and understanding social determinants of health is integral in providing personalized CF care. The second theme was increased availability of relevant information and resources in addition to follow-up on identified concerns. Shared information should describe the specific way these factors impact the life of a person with CF, and resources provided should address the challenges they currently face. And when appropriate and possible, there should be mechanisms for follow-up after sharing information and resources. Theme 3 is the importance of multiple touch points for messaging. Participants asserted that multiple touch points would reach a larger audience. Suggested communication channels included social media, of course, clinic handouts, and emails, but no single method was preferred. People learn and listen using different methods, so effective messaging requires utilization of all channels, even uncommon ones. The fourth theme is the acknowledgement of the impact of diversity, equity, and inclusion, as well as the disparities that exist in health outcomes related to race. The principles of diversity, equity, and inclusion should be incorporated into SDOH topics because social determinants of health contribute to inequities. Black people with CF experience delays in diagnosis, decreased access to treatment, more severe infections, and worse health outcomes, as one participant bravely shared. My daughter's diagnosis was partially delayed due to race. One of the physicians we later met again, who apologized almost in tears and said even after knowing she tested positive on a newborn screen, said if she hadn't been Black, I would have certainly considered CF and we probably would have had a diagnosis sooner. There are preventable causes to these poor health outcomes. The Black CF community has a long history of inequitable care and is stated in our health equity video, which you can find on YouTube. We should be intentional about incorporating health equity into everything that we do. Our fifth theme is the need for normalizing conversations to reduce shame, stigma, and embarrassment. These are all feelings associated with social determinants of health. Everyone within the CF community is susceptible to social determinants of health challenges, especially given the high cost of CF care. Studies demonstrate the pervasive nature of social determinants of health in the CF community, and it is not based solely on income, skin color, location, or employment. In many cases, it is a combination of factors, and often a person experiences more than one social risk factor at a time. Therefore, our communication efforts should include messaging that people are not alone in facing these challenges. Doing so may help reduce some of the shame, stigma, and embarrassment people feel, and may provide a sense of safety to discuss these topics. And finally, theme 6 is the identification of terminology and messaging that resonates with people with CF. The term social determinants of health is widely accepted and utilized in academia, but it does not resonate with people with CF and their families. While many understood the term after it was described, they still preferred some other term to describe these group of factors. One participant said, and I quote, "I think I would combine the health-related social needs and problems because needs to me is more positive, while problems is more negative. So there's both in this whole thing." There is a desire among participants for words with a positive focus because the term determinant and risk factor felt negative to them. Terminology matters. People with CF prefer the term health-related social needs over social determinants of health. In conclusion, these findings have informed the development of our department's future plans to share information about health-related social needs that includes clarity and uniformity of language, priority topic selection, suggested channels through which information should be communicated, and opportunities for messaging to care teams. These strategies may be applicable in other locations like care centers, but these strategies are not mandatory or prescriptive. Our strategy for communicating will include using the term health-related social needs instead of social determinants of health, discussing health-related social needs in specificity one at a time rather than in broad terms or in a group, and providing health-related social need content with relevance to CF and include resources to strategies to address the challenges with quotes and stories to reduce stigma. And we want to include facts about how this specifically impacts the CF population. We want to frame health-related social needs as a potential for impacting health outcomes, not as a determining factor in health outcomes. And this will convey that change can happen. And finally, we want to utilize multiple channels to message the content. These findings suggest that sensitive and thorough screening for individualized health-related social needs and the provision of tailored information and resources are crucial. Improved communication between people with CF and care team members about health-related social needs can help reduce stigma and a patient's sense of isolation and enhance relationship-centered communication. Since no two people with CF are the same, a co-produced plan that incorporates the people with CF's lived experience and the medical expertise of the CF care teams can increase the likelihood of a person with CF being able to follow their care plan. Ultimately, the goal of addressing health-related social needs is to ensure equitable care for all people with CF and reducing the overall impact of health-related social needs on an individual's health. The authors would like to thank the members of Community Voice for participating and sharing their valuable stories and insight. And I would like to thank the authors, and in particular, my colleague, Kristen Clem, for allowing me to share their valuable work. And I just want to encourage you to please feel free to use this QR code to receive information after the conference about CF Foundation programs and resources that are available to support you, your patients, and your families. Thank you very much.
Do we have any live questions from the audience?
Hi, Chris Drescher, Medical College of Georgia. Thank you, Kim, and all the speakers. I have kind of a general comment. I'm asking you because you are from the foundation. This is all coming with love, okay? So a lot of great presentations today and other sessions about the work around social-related health needs, around DEI work. And I've been reflecting since I've been here, and another part of my job, I'm the training director for our American Psychological Association psychology internship at MCG. And as part of that accreditation, I have to say what our diversity program is, how we promote training throughout for all of our interns, how we recruit diverse faculty, how we retain diverse faculty, and how we recruit diverse interns. And I'm wondering what it would be like if the foundation was requiring accredited centers to say, how are we recruiting diverse faculty and staff? How are we serving our diverse patients and their diverse health-related social needs? And how are we retaining patients that are different versus they decide to go to some other center because their needs are not being met? So I think if that was really seen as this is part of being an accredited center, not this is a cool thing you can do if you want to. I think that has the potential to really transform some CF care. So just any thoughts or comments you have on that?
Yeah, thanks, Chris. That's a great question and a great comment. And we are looking to think about more about DE&I and what can we do as a foundation and what do we have control over. There are some things that we have control over and there are some things that we do not. And we're going to be looking more into this within our long-term strategic plan. So you saw the postcards, putting in a little plug for you to complete that survey so that we can learn from you and determine what is needed. There is a lot of information on our website as well as from our DE&I work, but we do recognize that we need diverse care teams and we need to retain the care teams that we have. So I don't have any good hard and fast answers for you, but that is absolutely something that we're thinking about. Sure.
We have a question online, Kim.
Sure.
Are there any discussions about having a standardized assessment or screening tool for social determinants of health?
That's a great question, and there are so many tools out there. In our, we have a food insecurity QI change package, and it's available in the resources library and my.cff.org, and it lists a bunch of screening tools that are available. I would encourage you to check with your institution. CMS is going to require screening for health-related social needs in 2025, although it's kind of required now this year. This is kind of like a practice year for institutions. And I think it's going to be specific to your institution. So I would encourage you to figure out what tool you're using. But as long as the questions are getting answered or asked and answered in a sensitive manner, in a personal manner, I think that's all that matters.
All right, I think last one, unless there's another from the audience. Learning more about the social determinants of health, you mentioned cff.org. Can you say a little more about resources?
Yeah, so in our resources library, we have a social determinants of health toolkit, and I showed a quick picture of it. We have QI change package for food insecurity and how to get started. And really that QI change package could be helpful for really screening for any social determinant of health or health-related social need. And so I encourage you to check out all of the resources in there. If you get into the resource library, there's a wonderful search function. You can put in SDOH or food insecurity, and a plethora of resources will pop up. But if you have any trouble, just reach out to me and I'll be happy to share that with you.
Hi, thank you. I'm Sammy. I'm a social worker here in Boston. Really appreciating the distinction in asking patients about their preferences on the terminology HRSN versus SDOH. I think about those terms too. They mean different things. And so thinking about what we're assessing for and not wanting to lose some of what we're assessing for in social determinants or structural determinants. And just as in this conversation, I think it was Christopher, your comment made me think too of like, what if we were assessing our teams social determinants of health, of how well are we able to meet these needs? Because we put this on, we're assessing the patient individually. What resources can I find for you? But what are we doing institutionally, as a foundation, as our specific teams? How are we able to meet those determinants of people's health that we know affect? So do we have a diverse team? Do we have the resources? Are we using our funding to prioritize getting food on the table for people or keeping their insurance? Because we put that on the patient. They're filling out this survey. We screen for social determinants of health. But if we're not pushing that from the places where the money's coming from and where the power is coming from, it feels like a Band-Aid. So just wanting to speak to that language and appreciating that specificity, but not wanting to lose some of what we're assessing for.
And to be perfectly honest with you, the people with CF, they don't care what you call it. They just know they have trouble. They have trouble putting food on the table or turning the lights on or whatever may be happening. So it's literally having those conversations, but really having that introspection of figuring out what do you know, where are the gaps in your knowledge, and how can you have a non-judgmental presence when you're with people with CF? Because the health-related social needs, they affect every income bracket, and every person. It doesn't matter what kind of insurance you have. The food insecurity rates from our health insurance study in 2019, even for those with six-figure incomes, were greater than the general population. So it's just having those conversations and being comfortable with that. And looking into your resources, I kind of equate it to the mental health work that we did all those many years ago. It's the work before the work. Identify your local resources if you need help. Compass is always available to help the US-based care teams to identify resources. And even thinking out of the box, is the health insurance coverage the best coverage for that person? Are they paying more out of pocket than they should be? Are they using everything in the right order? Because maybe it'll free up some cash for something else later.
Great, thank you, Kim.
Thank you.
I want to introduce our next speaker, which is Dr. Rachel Slayer. She is a research coordinator for the Gender Research Lab at West Virginia University.
Good morning. My name is Rachel Slayer. I use she, her pronouns. I'm a research coordinator and postdoc at the West Virginia University School of Medicine. I'm here today to present findings from PRIDE CF, specifically healthcare priorities and needs for LGBTQIA plus people with CF, a concept mapping study. The PRIDE CF study is a series of health equity team science awards from the Cystic Fibrosis Foundation. It's focused on understanding the experiences and the needs of LGBTQIA plus people with cystic fibrosis and is a partnership between the institutions shown here. Here's the disclaimer, and then I have no relationship to disclose. LGBTQI plus people face significant health inequity. No prior studies have directly explored how LGBTQI plus identity intersects with cystic fibrosis to impact individuals' experiences, health outcomes, and care utilization. PRIDE-CF is the first large-scale assessment on the impact of the intersectional lived experience for this population. Instead of looking at only LGBTQI plus people or people with CF, what PRIDE-CF does is explore the intersectional needs of the estimated 10% or more of people with CF who are LGBTQI plus. PRIDE-CF aims to serve as a model for understanding intersectional experiences for LGBTQI plus people with other chronic health concerns. In the PRIDE-CF study, we recognize that LGBTQI plus people with CF likely experience impacts of minority stress, seen here in the top row boxes, while also experiencing chronic disease stress from having cystic fibrosis, seen here in the bottom row of boxes. We hypothesize that healthcare use, access, and outcomes will be impacted by both aspects of identity for this population, and this study seeks to better understand those likely impacts. Today, I'll be speaking about findings from Project 3, which is specifically a qualitative analysis of the experiences and health needs of LGBTQI plus people with CF. In this concept mapping project, LGBTQI plus people with CF and providers were recruited through the CF Foundation Community Voice Listserv and via snowball sampling. Participants utilized online group wisdom software to complete brainstorming, sorting, and rating activities for concept mapping. All concept mapping data was collected and analyzed through the group wisdom platform, and all participants were invited to participate in focus group interpretation meetings via Zoom video conferencing. Here's an overview of the concept mapping process. I'll walk you through it now. The process starts with brainstorming, which is where participants utilized our online group wisdom platform to individually respond to the prompt, things that people should know about the experiences of LGBTQI plus people with CF are. The research team then intentionally chose to consult with the PRIDE-CF community partner group to reduce and revise final statements for the next phase. Next, participants utilized group wisdom to electronically sort brainstorming statements into groups that were intuitive to them, and to also rate statements in 3 categories: importance to LGBTQI plus people with CF, importance for future research, and overall agreement. Once this phase was completed, the research team completed an initial interpretation and analysis of sorting and rating data before then presenting these preliminary findings to participants in the next phase. In the focus group review, all participants were invited, and in one of 3 focus groups, given the opportunity to analyze study findings, name groups of statements, and suggest possible revisions. The research team then incorporated participant revisions into study findings and sent the proposed final version of the concept map to all participants for final review. We incorporated this final feedback prior to dissemination at this conference. Table 1 shows the demographic distribution of participants in this project, including engagement in each of the core steps of concept mapping: brainstorming, sorting, rating, and focus group review. Participants brainstormed a total of 202 statements. These statements were revised and reduced down to 102 by the research team and through the help of the PRIDE-CF community partner group. This is a depiction of all 102 statements, distributed in accordance to how they were sorted. But before we discuss concept map clusters, I first want to highlight the statements that were most highly rated in our 3 rating assessments. With regard to what is most important for LGBTQI plus people with CF, the most highly rated statement was, LGBTQI plus people with CF want to receive the same validation, respect, and care as other patients. With regard to what statement was most agreed upon, growing up in a different time is not an excuse to mistreat LGBTQIA plus people with CF. And with regard to future research priorities, there isn't enough information for people with CF who are seeking gender-affirming care, hormones, binding practices, surgeries, etc., and the impact on our health. Here you'll see the final 6-cluster concept map reviewed and approved by our concept mapping participants. Multidimensional scaling and hierarchical cluster analysis were applied within the group wisdom platform based on similarities between statements and the sorting data to generate the initial cluster map. Cluster names were developed during the focus group review by participants And then outliers here are color-coded to match the cluster they were reassigned to during the participant feedback session. For cluster one reflects on the diversity of experiences and needs of LGBTQI plus people with CF and emphasizes that identity experience is different for each individual, with strong agreement that representation is important. Example statements include: the LGBTQI plus community includes a diversity of experiences and identities and may be fluid for an individual, and this is true for LGBTQI plus people with CF too. Keep asking and checking in with all people with CF about their identity and pronouns. Make it universal and not just target those conversations with known LGBTQI plus folks. Because of racist and ethnocentrist disparities in CF diagnosis, representations of LGBTQI plus people with CF remain artificially narrow. Cluster 2 centers on sexual and reproductive health needs specific to LGBTQI plus people with CF. Example statements from this cluster include: fertility and family planning is complicated and should be delivered without absolutes. CF care teams should ask about fertility goals before counseling LGBTQI plus people with CF about the potential impact of modulator therapy on fertility. Providers should avoid assuming patients are cisgender, heterosexual, and monogamous when discussing sexual reproductive health and family planning. Cluster 3 includes recommendations for needed education and training for CF care teams and others caring for LGBTQI plus people with CF. Example statements include: CF providers should be trained in safer chest binding practices. Consider having an LGBTQI plus champion as a part of the CF care team. Being an LGBTQI plus person brings additional challenges and obstacles that the CF team needs to ask about and help address. LGBTQI plus people with CF should not bear the responsibility of educating their providers about their health needs. Providers need education about how to navigate conversations about pronouns, including when they mess up. Cluster 4 provides strategies for creating a space that feels safe and supportive for LGBTQI plus people with CF. Example statements include: a negative interaction with one medical provider around LGBTQI plus identity can fracture trust with all medical providers in all medical settings. Folks will avoid non-urgent care if they do not feel safe and supported in their gender or sexual identity by their CF care team. When providers are not comfortable talking about LGBTQI plus issues, it is clear, and that makes it less comfortable for LGBTQI plus people to speak with their provider. Cluster 5 recognizes the reality of multi-directional stress related to LGBTQI plus identity and having CF. Example statements include: being part of the LGBTQI plus community and someone who has CF adds so much nuance and extra challenges to everyday life. Having to come out as LGBTQI plus on a routine basis and also having CF can be taxing. There is an additional burden of extra self-advocacy on the shoulders of LGBTQI plus people with CF. There is compounded economic disparity for people who have chronic disease like CF and are also in the LGBTQI plus community. Cluster 6 contains information related to gender-affirming care needs for gender-diverse people with CF. Not all people who identify as trans or non-binary want to have medical interventions. Gender-affirming care is equally as important and life-sustaining as CF care. Receiving gender-affirming care may benefit health in unexpected ways, including increased positive outlook and motivation to engage in CF care. There isn't enough information for people with CF who are seeking gender-affirming care, hormones, binding practices, surgeries, etc., and the impact on our health. Finally, I want to share with you some key participant takeaways. Within the focus group review, participants elaborated on key takeaways from the concept mapping data. Here they are. Visibility without being under a microscope. That being seen and not being under a microscope kind of balance. that struggle to find a balance between the normalization, accommodation wants within the community. That balance between how much mainstreaming might be helpful and how much kind of signaling that people are willing to go the extra mile, or explicit signaling that they want extra information from us about how to take care of us. Actual versus performative support. There isn't one avenue of creating safety. If someone's just checking a box with a symbol or something, that would, I think, become apparent and not feel safe. But when a clinic is truly trying to create a safe space, it's not just one way of symbolizing that or one approach. Dual stress. Combine intersectionality of your CF identity and LGBTQIA identity and the dual stress of that, or even just being intersectionality and dual stress. Individual needs, where it's almost like people who have very different experiences within the LGBTQI plus CF community. It's a little bit paradoxical because it's almost like there is a group voice saying consistently that individual nuanced treatment matters a lot. So it's not a bad kind of surprise at all. It's more like beyond people with CF, the LGBTQI plus community is often stereotyped as both a monolith and fraught with really contentious identity politics. LGBTQI plus people with CF have unique healthcare needs. However, there's a current lack of knowledge in this area. Pride CF concept mapping is the first step towards developing necessary educational interventions and further research on how best to improve care for this unique population. Pictured here is the full Pride CF team. I am profoundly grateful to have the opportunity to work alongside these dedicated, insightful researchers. Pride CF also includes a formal partnership with the Pride Study, which is the first long-term national health study of LGBTQI plus people. Thank you so much for your time and attention. I want to thank the amazing team I get to be a part of, who make doing this work all the more rewarding. And I want to thank each and every one of the LGBTQI plus people with CF and all the providers who entrusted us with their stories. Profoundly grateful. And also a quick plug, you can sign up via the QR code there, and we have a few lanyards left too with the QR code. This is our quarterly newsletter. We're really just interested in building a network and keeping everyone connected, because it takes a village. So please sign up, more information to come. We also have flyers up here as well. Project One, which Greg Sawicki is heading, is launching a recruitment officially, so please take a flyer. That'd be super helpful. Thank you all.
So we do have time for questions, if there are any questions from the audience.
I'm Juliana. I'm a psychologist at the Pediatric Center in Texas, or a Pediatric Center in Texas. I'm curious if you guys got any responses from participants in states where gender-affirming care has been banned, and like what they said. I find it challenging for our patients because it's hard to get them to the care they need, but we want to support them as a CF team as well.
Yes, we did. We have not completed those analyses to look at, responses specifically by those states. We did get a pretty representative sample from all over the U.S., like each of the regions, and we have not looked at specific responses based upon that, but we do intend to do so.
Great, thank you.
Yeah.
I'd say first, thank you for doing this work because I feel like it's like super, super important. I know that this is the beginning steps. But I'm hearing a lot in the concept mapping that you were doing about clinicians and about making sure that they have the education that they need. Is there any kind of beginning steps in education there? Is there anything that's maybe coming down the pipeline for clinicians to help educate them about LGBT?
Yes, that is that is definitely one of the goals of Pride CF, and that's why, obviously, as you said, we're just getting started, and the whole concept mapping was the first to launch in Project 3. It was the first to launch because obviously the place you want to start with is going directly to the community to make sure that we're getting a clear understanding of what they're experiencing, what their needs are. And then from there, it's a matter of also talking to providers. So Project 2, that's being headed by Tracy Kazmersky, she's focused in on providers and understanding what the care gaps, what their educational and training gaps are. so that ultimately we can kind of bring all of this together so that we can have better answers for all providers, because that's the goal out of all of this, right, is to make sure that CF care centers are inclusive, affirming spaces for all. And in order to do that, we need to make sure that we're maintaining communication so that we can all benefit from what the community is telling us.
Hi, thanks so much. I just want to put in a quick plug for tips for CF teams working with the LGBTQIA plus community from the Mental Health Advisory Committee. A lot of folks that are part of Pride CF were the folks that put that together. So that's found on my.cff.org, or you can email mentalhealth@cff.org if you can't find it.
Thank you so much.
So there is a question. Can you talk to us more about how the statements were reduced from 202 to 102?
Yeah. So we had very vocal community that gave us a lot of really great ideas. And that was honestly the hardest part, was that, we knew that if we asked our participants to sort and rate 202 statements, it would be exhausting. 102 was already, I've heard, plenty for them. So we had to find a way to systematically reduce that. We did our best to find any overlapping statements. We essentially did like a qualitative thematic analysis to, sort statements into piles and figure out where there was redundancy, if there was anything we could eliminate or maybe consolidate into a single statement. We did our best to do so, and then to cross-check the procedure that we applied, we went and met with our community partner group and said, hey, are we getting this right? And showed them examples of, here's where we started, here's the statement we have, do we think that this works? Does this make sense to y'all? And they were honestly really crucial in being a check-in place for us to make sure that we weren't misreading, misinterpreting anything that the LGBTQI plus people with CF or providers were saying to us, and to make sure that we weren't unintentionally excluding any important themes that needed to be carried over into that final sorting and rating phase.
Thank you.
All right. Our last one for the morning is with Cynthia George. She is a nurse practitioner with the CF Foundation. She's working in a space of trust, building partnership with patients and families.
Well, good morning, good afternoon. It's a pleasure to be here with all of you. And I represent, I just really represent this work from the foundation. But the folks in the room here, there's several researchers, trust researchers that we're working with. Many deep thanks to many people with CF and families who've decided to raise their hand and come forward for this work in trust and partnerships. And to the many CF clinicians, both in the adult world and the pediatric world, who are coming together to start exploring this work in I think what I'd like to say is a groundswell, and hopefully it's going to continue on. So this is their work that I represent. I'm honored to actually oversee the work and be able to try to fund it through the CF Foundation. So trust and partnership. This is a quote that came from, it's unpublished, but it's entitled, "It's hard trusting someone with your life expectancy." So people with CF and families have identified trust as an essential component, right, for partnering effectively with their care teams. And this came about from analyzing the first version of the patient care experience survey, where they took the open-ended text and they did a qualitative analysis of that. I want to just point out the interesting piece is that trust surfaced throughout so many open-ended texts, and it was never part of a question. Trust was never even mentioned. So I think that's pretty significant when you think about that. So if you step outside of CF and you look at the greater healthcare literature, you'll see that there's trust, high levels of trust are associated with many outcomes: improved adherence, improved health outcomes, completion of screenings and checkups, and stronger relationships. So it's clearly something that we want to focus in on. So this is the model that the group developed that we're doing the analysis of the experience of care survey. And so this is foundations of trust, where if you look on the left side, this idea of trusting my care team and then feeling trusted by my team were really key elements for developing that partnership and sustaining it over time. So let's zero in on that trusting my care team. I don't think we have a little circle, do we? But it doesn't matter. Well, if you bear with me over there, on this sort of, you'll see that what's elements of trusting my care team from the perspective of people with CF and families is, are they taking into account what I'm thinking, what I'm observing, what I'm feeling? And then if you zero in closer, you see that factors associated with trust are, how competent do I feel that that provider or care team member is? How reliable are they? How much do they know me beyond the fact that I have CF? How caring do I feel that they feel towards me? Do they listen to me, truly listen? And how about communicating? How do we communicate with one another? Is it bidirectional or unilateral? And then they felt on the opposite side that they really felt that they felt trusted by their care teams when things such as honored as decision makers, or that they felt listened to, and that they felt respected as an expert for their experience of life and what they can contribute to what they know that they need in their health. So when these things were present, again, that's when this sense of partnership was really at its optimal. So some things that we've also been learning over time is this idea of trust, is that it's not usually an on and off switch. It's not like I trust you, something happens, and then we're totally mistrust. It's usually something more along this like image of a sine wave, where there's peaks and there's valleys. Or in our new editorial that came out in JCF this week, which I hope you'll look at, it's on trust, and we're calling it wobbly moments. And the reason that this is dynamic with the image of a sine wave is that trust can be built, it can be maintained or reinforced, or it can be drained by messages, words we choose to say, behaviors we choose to engage in, or perhaps it's external to us, and it's the processes or the policies of institutions, states, governments, things like that, that can impact that relationship, sometimes, again, when you don't have control. So trust is dynamic. Let's look at some of the messages that we've heard from people with CF or stories that they've shared with us. In this first, you see, my doctor offers suggestions, but ultimately the decision is up to me to accept or reject the plan. This has built an incredible level of trust. So this adult with CF, right, is highlighting that idea that they've been feeling respected as an expert of their body. They're part of making the plan. They're the co-producing plan together. Really a great level of trust is in that partnership. But let's look at this one. This adult is sharing that we've worked hard to build trust with our care team, but there were countless times when it felt rocky. And so here's that probably wobbliness, and really rocky to me sounds a lot sharper edges that have been happening. And lastly, we hear, I found it very helpful, this is from a father with a child with CF. I found it very helpful when a doctor would explain something to me in a reasonable way. That does build rapport and strengthens trust. So, they're building that relationship. They're seeing me beyond CF. When the kids are sick, I want to know what they're doing and how it's going to work. So that competence, the father is seeing the competence in those providers. And when the kid is healthy or doing well, it would be nice, though, to have the doc reach out. So here's an expectation of potentially a process or a system that they wish was in place. So let's switch for 1 second, because this abstract was on how does the Partnership Enhancement Program, or PEP, I don't know if you're familiar with it, I'll just run you through it. How does that bolster and foster trust in a care partnership? So let me just pivot for a moment with that background as trust. The Partnership Enhancement Program, or PEP, some of you may be familiar, but if you're not, let me just run through a little. It's a relationship-centered communication. That's kind of a different course than I had ever been involved in. And you see the picture there of the people talking. And the reason I highlight that is because it's around the dynamics. We are asked to really be intentional and look at the dynamics that are happening between you and that other person, or you and that family. And by doing that, you're really fostering this mindfulness to look for and check in with that other person on how our words and our actions are being received by that other person. And that offers you these skills to really honor the person's lived experience. What is their life experience? Who is that person that is with me? They're not just CF. And it allows you to explore and understand their perspectives. Here's where that curiosity comes in that Dr. Ratner talked about, right? What is that curiosity? What is their life like? What, to Kim's point, what are they dealing with health-related social needs? And the idea of expressing empathy, verbally and non-verbally. And when one does this, one outcome might be that you see, you hear, and you better understand that individual and the context with which they live at each day. So let's look really quick at the overview of the PEP skills. So we teach 3 skills, and my PEP facilitators are in the room, for which I hear Chandra too, which I'm really grateful for. So the first is really getting intentional. Again, back to what Dr. Ratner had said. Let's try to busyness all day long. We're multitasking. But if I really want to see that person in front of me, let's try to zero in on them. Let's ground ourselves. Sometimes we talk about, taking a deep breath or something, whatever works for you. Really reach out to them first before that big talk about CF and what's the plan and what's going on. How are you as a person? What's going on? Try to reach out, connect beyond CF. And then I think most important also is what matters to you. We certainly have, right, a big list of things we want to get done. But let's first start with that person. What matters to you? What's concerned? What do you want to talk about today? And then together, add your clinical goals or the team's goals, and let's negotiate that together. Let's make our plan together. Let's co-produce our time together, whether that's on the phone or in person or telemedicine. So skill set 2 is really then leaning into an open dialogue. You've made your plan together. You're still looking at that other person. You're giving them that space. And find out through open-ended questions what it is that they want to talk about. What is their perspective? What are their ideas? How is something impacting them? How are they feeling about everything emotionally? And our job at that point is to listen. Listen to reflect what they've said, not listen to reply. I don't know about you, but certainly I'm guilty of listening to reply. But through these skills, I've really hopefully honed in a bit more on really listening to reflect what the person is saying, and also to cue into the name of the emotions. How are they feeling? And perhaps test that out. I hear you're really sad, Carol. I'm not sure if I got that right, but that's what I'm hearing. And then through, we respond to, sorry, Carol, you're sitting right in my line of sight. And then we respond with empathy. We call it using pearls, but it's an empathetic statement, and there's also nonverbal expression. And the last is setting goals together. We share information. We have so much information that we want to share. We just need to be cognizant of not what we call downloading it all in one dump, but really engaging in that dialogue, breaking it up into chunks, checking in with how that person is really absorbing the information. And then we use a thing called teach back, which is not quizzing the person, but before we end the conversation, what are you walking away with? Did I really convey what I thought I was in a clear manner? And then how do we intentionally close that visit as much as we intentionally started the visit? So those are our PEP skills. So how good do they do with the trust work? I'll talk to you in 1 second, but I have this to just say that it does support equitable care. We explore perspectives, we honor a person's lived experience, and we seek to understand that does aid in the creation of open communication. And coming from this reference on the bottom, also communication skills are foundational to promoting equity in healthcare, practicing medicine safely and effectively. And I do want to share.
I don't think you can succeed at being healthy if you don't trust your team. And again, it goes back to having that open dialogue. If you don't have that trust to have that open dialogue or that confidence or that comfortability, you might have the wrong team. Because the last thing we need is to not be heard. Not just as a CF patient, but as a Hispanic, as a Black, as a minority, as a woman, as, a member of the LGBTQ plus community, we already struggle with being heard on our daily life. Mm-hmm. Your medical team is somebody that you're trusting with your actual life, and then to not feel heard and not have that trust there is very worrisome.
So really grateful to this adult with CF who's participating in our qualitative research to understand trust more from various communities that we do not hear enough of. And so that clip hopefully stresses, again, communication, really essential, hand in hand with developing trust and seeing the person of who they are. So the goal of this project, in my 2 minutes that I see I have, was again to map, did the PEP skills, how do they do in helping to foster trust? Well, here's our model again, and we can see that open-ended questions do help recognize, like, what is that person's perspective? What are they thinking? Pulling that in a greater way. Sharing information. Really, the person can observe, but also participate in what exactly the information is being shared and being part of it. How am I feeling? The expression of empathy is right there. Negotiating that agenda is really helping to reinforce that they have a role as a decision maker. Active listening really helps you feel listened to. And setting goals by partnering really respects the person as that expert. So not too shabby with these PEP skills, reinforcing trust. And here might be how they might sound. So the competency factor that I mentioned before, if you're sharing information in chunks, perhaps it sounds like, build on what you already know. Here are 2 pieces of information that might help us develop a care plan. Right? That's a little bit different than saying, hey, here's 2 extra pieces of information. Let me acknowledge you first and move on. And knowing me. I know that you work full time and it's important for you to go into the office twice a week. How are you feeling balancing your priorities with this care plan? Really checking in. What's going to happen when you leave? Are you going to be able to manage this? Honoring them as an expert. Let's look at the PFT results in a minute. First, tell me what your changes you're noticing in your health. You know your body. And lastly, respect as a decision maker. I appreciate all the effort you put into caring for yourself. What strategies have you used in the past that might help you manage your treatment? So I leave you with trusting care partnerships. That is dynamic. It's impacted by our words, messages, our behaviors, and also outside of ourselves, right? Whatever systems and places our clinics have, our institutions, our organizations, our states. That the duration of our relationship and positive feelings that we might have with our people with CF and families who we serve, that's wonderful. It does not make it immune from the dynamics of trust. And as this landscape has changed and we put the lens of health equity on a tighter fit here, we understand that there will be different perspectives. Perhaps people aren't going to want to come into clinic. They already aren't. But those viewpoints are okay. They're just different perspectives. We have to recognize them and lean into the skills of which you can take action to build, reinforce, and restore trust through awareness, the use of resources, and augmenting your communication toolbox. I know I'm just a little late. I just leave you with a couple things, so I think you'll get the slides. You know, I just invite you to think about what words and actions you engage in that foster trust, what systems and processes are in place in your organization, your center, that help build trust. And if you really want to learn more, there's a new resource out. We're all going to run over, Chandra and I are at any rate, to Building Trust in the Care Partnership, which follows this. It's a new resource about the welcoming experience, not of a new diagnosis, but someone transitioning or transferring, where it's not one moment in time, but there's things you can do to build trust before, during, and after a visit. I also, in case you're interested, I don't see Dr. Grove here, but she is leading a team to learn, there you are, to help understand more experiences about trust, especially with the folks that we've been talking about today, and as well as Indigenous, Asian American, and other folks who are not eligible for modulators. We'd love to hear their voices as part of the study that she's leading. And there's also the Partnership Enhancement Program, has new applications, and I'm really happy to say that we just did a pilot. I think it was fairly successful. It gave us a good signal on Wednesday on communication skills to enhance equity and inclusion. So we're taking the PEP skills, adding a DEI lens, and humanizing healthcare. I think we have a lot more we'll do next year. I'm grateful to all of these people and to all of you for taking the time to listen. And thank you. Thank you for all you do.
We have a question online. We have a couple minutes. Any questions from the audience before we wrap up today?
Hi, thank you for that talk. I think this is more curiosity, or maybe there's actually been people reporting with PEP, but you mentioned the importance of nonverbal expression, which I think is always really important. And of course, that has been challenging over the years with COVID and everything. And so do you feel, or have there been reports of our families, persons with CF, feeling like a lack of relationship related to masking, or has it been more of a solidarity and support and more of a rapport builder? Because I think, now with not having as many requirements to mask, some of us now still mask in our clinic routinely, and some of us don't, which is fine too. But how has that affected the community, do you think?
Yeah, that's a great question. I don't know the current state. I know prior to the pandemic, right, when some clinics were masking before, that people were noting that before they go in, they sometimes would just show their face, because people had said, hey, that's kind of a barrier. I don't really know who you are. So they had, before they entered into the room, they would show their face, make the connection with their eyes, with their smile, and then put things on and go in. So great question. I'm sorry I don't have that information.
No, that's okay.
But it's
Thank
a great
you.
question. It's a good one, actually, to check in with people, right? You might check in. I'm realizing this mask is a barrier. I'm wondering how that's feeling for you. Yeah.
Cynthia, how could these partnership skills, the PEP partnership skills, actually support DEIB?
Yeah, well, China, what do we think that's? We're hoping to have that out again next year. How do they, I think, that just the bottom fundamental is that they see the person as the person, right? You are really seeking to understand who that person is, no matter what they look like or don't look like, because, there are identities I have you don't know that are marginalized. So that's not really a great answer. Stay tuned, maybe.
Great, thank you.
Okay.
So we just want to thank everyone for all of our presenters today, as well as everyone that came today. And we know that some people came to this workshop due to feeling the need to be more conscious of diversity, equity, inclusion. And some people have come because they continue on their lifelong journey of learning all they can to promote and live out diversity, equity, inclusion. But whatever your reason may have led you to this workshop today, we want to say thank you for coming. And we also ask that as you leave, that you open your heart, open your mind, and commit to one thing that you can do to promote diversity, equity, inclusion in your personal and professional lives. We want to say have a great afternoon and know that this work can start today. Thank you.